is a very simplified way I have prepared it to give you some tips and tricks how to go for the clinical examination. So mechanical axis relevance for clinical features, everybody knows that the long axis deviates this way, that way, will make you the varus or the valgus. It's very simple. Everybody knows it about this thing, that how much deviation will be there for the varus, how much. So ponder fast mechanics, then mending, or fast mending, then the mechanics. It's difficult to know about that. So see, these are the cases of osteoarthritis. They usually come at the end of the journey of all treatment. As in the outset, Jugas has told us. And you see, people come like this with the gate, and we go for the examination. So this is the way they take the support, either a crutch or the help in the hands of the assistant. So this is everybody knows about these things. I'm not going into that. Yeah. So faulty mechanics and empty measures, and thus deformity waddles to the destruction. And orthoscanogram can tells you about the coronal, but fails the sagittal, whether there is any flexion deformity or cannot. History of other causes, aging process, defective lubricating system. See the cause, bent at the knee, at the horizon. This is not at the not conforming to the horizon. You see, there is the obliquity. So wear and tear. What is the history? History is the obesity. Is very important to see for the obesity, and abnormal mechanical loading is there. See, they can correct the angulation by this. So clinical manifestations from known pathology to the unknown direction of all tissues around the joint. So for clinical examinations, we look at the face of the patient first. Then we look at the eyes to feel the storm inside. Begins the clinical journey when he or she walks in, inspecting the general systemic and the local changes, more or less than not. Feel the soft tissue and the joints where it hurts. Ask to move, assist to get more or less. Measure your 3 measurements: length, girth, and the angle, to record, retrieve, and plan for editing. And often then turns a doubting Thomas, confusing with the differential diagnosis. Friends, finally, the friends of the investigating tools get you to the destination to plan, play the game of treatment, and prognosticate. So, what the clinical manifestation is? Attitude, torso, positioning, balance, and fitness of the patient. But if the gait changes started, when it started, orthosis, shoe, stick, splint, caliper, which is coming into your clinic, walking distance is reduced, ADL loss, rest pain, whether there is a rest pain or work pain, or there is a night pain, that is important. The spine, hip also will follow. Skin changes, swelling, there will be locking, deformity, low bone health under the treatment of the teriparatide or bisphosphonate, muscle bulk and strength. Is see in the COVID situations like this, I can give you some tips. One is the Nasorma, another is the Socrates. So what is this Nasorma is? Nasorma that you write in your prescription pad, name, age, sex, occupation, residence, mode of presentation of associated disease. And Socrates is nothing but the deformity, limitations, inability, pain, and swelling and limb. So what the Socrates in short? Site, onset, character, radiation, association with others, and time of the course, exacerbating and diseasing factor, and how severe the pain is. See, the profile cannot be seen from the back. Because is there any flexion deformities? Clinical features: pain, 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 and pain. Usually low onset of discomfort with gradual and intermittent increase. Pain is more on weight bearing due to the stress on the synovial membrane, as all tissues around the joints are affected, and later on due to the bone surface, which are reached with nerve endings coming in. So diffuse, sharp, and stabbing local pain. And see the mechanics that has been changed a lot, whether there is a horizontal translation. So these things will come with lost alignment. Patients will come like that with clinical features of pain. What are the types of pain that you face? Mechanical, then increase with the joint, inflammatory in the phases in the beginning, rest pain later at 50%, night pain 30%. So the clinical deformities you see for the soft tissue swelling, mild synovitis, remember osteoarthritis is mild synovitis, small effusion, avoidant nodes for the osteophytes and joint laxity because of the ballooning of the capsule. So asymmetrical joint destruction leading to ambulation. So what the clinical features of movement? Gailing stiffness at the period of the inactivity, 15 minutes in the early morning stiffness, pores capitis palpitant here, flecked of cartilage in evernated borders. We have to the patellar grating for petrofemoral way, L5 tenderness for the lumbar spondylosis, ankle joint tenderness, and osteoarthritis the hip by seeing the rotations of the hip. So reduced range of movement, capsular thickening, all has been muscle spasm. So what is the summary? Loop, feel, move, measure. A patient with the typical way of the knees, the normal standing posture, there is a mild varus angulation of the knee joint due to symmetrical way of the medial tubular. So what is the clinical feature to look for the examination? Valgus test, varus test for the laxity of the ligaments, Lusman test for the anterocruciate, McMurray test for the meniscus, and waddling, dark waddling for the step. So severity, stage 1, stage 2, stage 3, stage 4, minimal way changes, the minimal joint diminution, or there is a decreased joint, more decreased joint to the osteophytes, and alignment is lost in stage 4. So differential diagnosis, as you have got all the investigation to filter out whether it is osteoarthritis or something else, that we have come to a point that it is osteoarthritis. So osteoarthritis again have got 5 gradients, you see, medial pain, lateral pain, diffuse pain, anterior. So in the medial pain, there will be osteoarthritis, medial collateral ligament, meniscus, and dorsal. In the lateral, there is lateral collateral ligament in the middle and the iliotibial band. In diffuse pain, anterior pain, osteoarthritis, patellofemoral syndrome, patellofemoral bursitis, and quadriceps mechanism. And in the diffuse pain is infectious arthritis, gouty arthritis, pseudo-gouty arthritis, rheumatoid arthritis. This has got the diffuse pain, not sharp pain, remember. And posterior pain is for the Moran-Becker system, all osteoarthritis. So as already told by our Jogesh, this monofocal, the primary way or secondary way. So this is just a glimpse of the primary way and the secondary way that everybody knows. So take home track is that aneurysm, where there is a smoke, there is a fire. So where there is a deformity, there is the deceleration. And see, for the bone ends that rub together, that eroded cartilage occurs in the osteoarthritis. Whereas the swollen inflamed synovial membrane in the rheumatoid arthritis. So worsens with activity, relieves with rest, whereas it is worsens with the rest and relieves with activity. Thank you very much.